Good afternoon, everybody, and I'm so fortunate to have a distinguished panel of experts here. Initially, I thought it was probably going to be a panel discussion, and I'm supposed to put questions to them, but then I saw I have to speak on it, and Abhijit also pointed out. So, like the medical counterparts, we do not have any proposed or any criteria for uh, defining also what a surgically complex living donor is, nor do we have any very significant amount of literature to come across and define our own guidelines on this topic. So when I gleaned the literature and I came across whatever I had, and then I have also tried to personalize my some data based on my own experience. So this is a unique clinical and ethical dilemma. It's the best possible treatment. We all know that, and so much has been covered in the previous two talks. I don't need to really emphasize every point, but we have to now see that the long waiting lists of patients who need a kidney transplant, it compels us to really think about accepting more and more marginal donors, and that also includes patients or donors who have surgically challenging anatomies or pathologies in them to really donate. So here, during any decision making, we have to really remember that this is the only surgical condition, especially in a country like India, where one has to figure out if the patient is lying to us for money. There's a lot of thing coming out, and we know so many things, so many scandals being executed. So the aim of workup, it has been spoken of in general, but for a surgeon, it's to eliminate all the modifiable barriers to living kidney donation and to remove an organ with as few adverse effects and consequences to either the donor or the recipient as possible. So the donor screening for conditions that will impact his or her mortality and morbidity risks during and after the donation has to be paramount. Sidewise, likewise, simultaneously, the donor's organ must also be assessed to ensure that the recipient will receive optimum function, the organ is anatomically feasible to implant, and the risk of disease transmission through the organ is minimal. So, while defining an acceptable risk, what it is, we have to be having an interplay of so many factors. So it's basically to balance a diligent inquiry versus a justifiable investigation. So we should not be appearing to make unnecessary inquiries and sound morally policing the really well-meaning donor. Sidewise, we also have to so many times depend upon the workup of the donor that has been done by our medical colleagues and really leave things to that. For surgeons, there is immense pressure of not operating the patient to alleviate an existing illness. Normally, we operate to treat a disease or an illness, but here we are operating a normal man and making him into a patient. And this, for this reason, this becomes not a mundane surgery that we do every day. So perfection and zero complications is always the expected outcome, both for the patient and for ourselves. And we are directly responsible for inflicting an unnecessary injury of removing an organ and controlling immediate risk to the donor. No unforeseen complication is justifiable. So, what are the surgically complex issues? The list is long, but half of it was all medical problems. So nowadays we are seeing more and more older donors because by and large the donors are usually parents or grandparents. Obesity has been discussed in detail. What we need to also look at is the complex renal vascular anatomy, presence of kidney stones, tendency to have a PUJ obstruction or an existing PUJ obstruction, and tumors. Tumors also not in the kidney, but also there's a paper on restored kidneys, which is the last slide in this presentation. Obesity, as we know, has been closely linked to CKD. There was a detailed discussion in the previous talk. It is a significant amplifier of problems of CKD in the presence of diabetes, hypertension, and cardiovascular disease. What it causes is mesangial expansion, hyperfiltration, and likelihood of proteinuria. So in our country also, like in the West, there's a obesity epidemic going on, and we have more and more number of patients coming to us with uh, donation problems. And in our country, the truncal obesity amounts to almost 40% of the donors when it comes to living donation. Implications: so 25% of the donors who come to us are obese. There are high chances of surgical complications in these donors because of the obesity itself. They must be encouraged to lose weight prior to donation of surgery. There is a school of thought on this. What is the modality of losing the weight? Some are advised to take up bariatric surgery, and the type of bariatric surgery preferred is a sleeve gastrectomy over the Roux-en-Y type because of the fluid and electrolyte imbalances and the high incidence of nephrocalcinosis which has been observed in this type of surgery. And it also causes a resolution of diabetes mellitus and hypertension in 50% of the patients 8 years post bariatric surgery. Hence, it is advisable to encourage them to undergo bariatric surgery, especially if the BMI is extremely high, that is more than 35 in our Indian scenario. Lab nephrectomy also becomes feasible if a bariatric surgery has been done, so it's not a contraindication. Structural variations is the next thing we have to look at. So kidneys are very commonly known for accessory arteries, which we see in almost 30% of the patients. So what are the accessory arteries? They have been defined differently. Entering through the hilum are known as accessories. Entering elsewhere in the kidney are called as aberrant arteries. And the aberrant ones or the accessory ones can arise anywhere from the mesenteric artery, the median sacral artery, lower thoracic aorta, inferior phrenic artery, splenic artery. So the imaging has to be done so that all these areas are also covered and looked at before we actually donate. So commonly what we see is the renal artery and the renal vein. They arise from the aorta and drain into the IVC. However, sometimes usually the renal artery arises below the celiac axis, but there are instances wherein the right renal artery specifically arises higher up. It can also go as high as up to the thoracic region, and this we should not be missing while we are actually harvesting a donor kidney in such patients. Another very important factor is the renal artery stenosis, especially in older donors. So in such patients, it becomes mandatory that we harvest the kidney which has this ostial stenosis and try to exclude it from our area of anastomosis. Smaller upper polar arteries are the ones which sometimes create problems to us because they are often missed on the newer methods of imaging, especially in the CT scan if they are not looked at properly, and especially when the length of the artery is very small, as has been seen in the first slide. Earlier, the selective angiograms, when conventional angiographies were being done, they were quite indicative of identifying such arteries, and we really miss these angiograms in day-to-day practice now. Dealing with the upper polar artery, whenever it is available in good length, they can be directly anastomosed to whichever available recipient artery we have, and otherwise they have to be probably, if they are not contributing significantly to the function, they probably may have to be sacrificed as well. Now, this is internal iliac artery offers a very flexible mode of using in case of multiple arteries. With its branches, we can definitely accommodate 2 or 3 number of arteries in the donor kidneys. As can be seen in this video, the internal iliac artery was harvested along with its branches, and 2 of the branches were utilized to anastomose the 2 arteries of the donor kidney. Sometimes there is a problem of single artery but with early branching, so there is not much space to either clip the artery or ligate it, and we might come across a scenario wherein the ostium is very small, and in that case anastomosis has to be done carefully so that the lumen of the smaller artery is not occluded in our suture line. Here is a case where a donor artery with a common ostium was anastomosed, and both the arteries are filling well after the anastomosis has been done. Renal vein thrombosis. Now, this is a peculiar case which actually happened in my hospital about a year back. We had a donor who was a mother, and she was going to donate to her 40-year-old recipient. However, the recipient also had a coronary artery angiography done, and that's why wherein he was found to have triple vessel disease, and he was made to undergo CABG. And that CABG and post CABG convalescence, it consumed almost a year. And after a year, when we took that patient for surgery, we had chosen the right kidney, and the right kidney was actually done laparoscopically. It was harvested with a IVC cuff, and when it was anastomosed, we found that the renal vein was not filling up, and the kidney was having renal arterial hypertension. And when we then checked, the renal vein was found to be totally obliterated in the lumen. The part of the lumen which was adjoining the IVC cuff was patent, but nearer to the hilum, it was totally occluded. And that is why this kidney had developed collaterals, and those collaterals were actually sacrificed, thinking them to be accessory veins, and they were not of significant caliber. And so in that case, what we had to do was undo the anastomosis, and then take a saphenous venous graft, put it to one of the patent lumens of a developed collateral vein, and then it was anastomosed. And post-operatively, the recovery was uneventful. And this is a small video which shows how the vein was put, and the patient was discharged at a creatinine of 1.6, and 1 year follow-up, he is having a normal creatinine. Retrorenal veins or the other venous anomalies are very common, especially keeping in mind the development of the IVC, which comes from the cardinal veins, the supra, sub, and the posterior cardinal veins. The growth, regression, and fusion anomalies, they can lead to various combinations, and they have to be kept in mind when we are harvesting. Especially now when we are having more and more donors coming into paired exchange programs, the complexity deepens further, and 60% centers refuse right kidneys, and especially right kidneys with multiple renal artery kidneys, because the recipients in the domino chains, they would not like to have any kind of risks taken for their transplantation surgery. Double ureters is another surgical complexity we have to keep in mind, that while we are harvesting these ureters, we should be careful that one of the ureters is not compromised in its blood supply, and it does not subsequently end up into either necrosis or in stenosis. This is a video that shows a similar full-length ureter that was taken up. The ureters were anastomosed with a common ostium into the bladder with a Lisch-Kreger technique. Another example, here you can see both ureters being formulated into a common ostium and being put on the bladder. This is another case wherein there was both the ureters were ending separately into the donor bladder also. They were harvested, united into one ostium, and again put on the recipient. Oftentimes there is some mishap which happens and which renders the length of the ureter not significant enough to be transplanted into the bladder. Here is one case wherein the ureter that we got was just about 2.5 centimeters. So in that case, what we had to do was we had to take up the native ureter, bring it closer to the kidney, and anastomose it to the kidney, instead of using a deceased lengthy ureter of the donor. Malignancy is something which is being looked at, and we definitely have incidental picked up kidneys with incidental omas, and there is a problem on which kidneys to take and which kidneys to discard. There are some criteria that have been defined now, and there are some malignancies which are considered as low risk category, and they include these malignancies, that is small RCC, low grade CNS tumors, primary CNS mature teratoma tumors, and so there is a list of all these categories depending on which we have to decide wherein we should actually go in for taking kidneys from such donors or not. Donor CKD after nephrectomy versus partial nephrectomy. This is a well established fact now that partial nephrectomy in tumors smaller than 3 centimeters is a preferred choice, and such kidneys can safely be taken up for donation. Now, there was a paper on restored kidneys from Japan wherein they had very high risk or diseased donors which were considered for donation in desperate recipients. In such patients, they had a list of about 42 kidneys which were taken from patients with benign tumors, ureteral cancers that were really significant, vessel aneurysms, ureteral stenosis, and severe nephrotic syndrome donors also. And the survival rates this paper reported were to the tune of 3, 5, and 10 years were in the tune of 92.9, 89.9, and 79.3%. So the amount of desperacy can really lead us to take up really very poor kidneys also, such as the severe nephrotic syndrome donors. There were almost 8 patients in this series which were taken up, and they all did well. 5 of them survived for more than 5 years, and 3 of them were lost to reasons not pertaining to the kidney. And that's how the thing is. And thank you so much for patient listening.